Welcome. Great place to be. 8 o'clock on, first day back. Yeah. Welcome. Madam Secretary, please call the roll.
Senator Rocky Adams, Senator Thayer,
Here.
Senator Yates, Representative Bridges, here. Representative Frazier Gordon, here. Representative Grossberg, Senator West,
Here.
And Representative Lewis.
Here.
We have a quorum.
With quorum being present, the subcommittee is duly constituted to do business. First matter of business is approval of the minutes. Do I have a motion?
Motion.
Do I have a second?
Second.
All in favor?
Aye.
Aye. Are there any? Without objection, it is so ordered. First time, guys. Please call the first regulation.
Kentucky Higher Education Assistance Authority, 11 KAR 4080, 5001, 037, and 145, all with staff suggested amendments.
11-4080 is being amended to incorporate the latest version of the free application for federal student aid that are to be completed by applicants for participation grant programs administered by the authority. 5001 is being amended to add 4 new categories of non-citizens to the eligibility list for the grant programs administered by KHEAA and 1 category of non-citizens to the ineligibility list for consistency with the federal Pell Grant eligibility criteria. 5037 establishes student eligibility criteria for the College Access Program. 5145 is being amended to increase the maximum expected family contribution level necessary to demonstrate financial need for eligibility for the CAP grant program and increase the overall annual maximum award amount for recipients attending a 2-year or 4-year institution. The staff suggested amendments to these regulations amends various sections to add and delete statutory citations, comply with the drafting requirements of KRS Chapter 13A, and make technical changes.
Would you please identify yourself for the record?
Is the green button on the microphone?
Okay, sorry, it is now. Shall I repeat that?
Yes, please.
Okay.
Thank you.
Good morning, Diana Barber, Interim Executive Director for Kentucky Higher Education Assistance Authority.
Thank you. There are staff amendments. Is there a motion for approval from the staff amendments?
So moved.
Second. Thank you. Without objection, it is so ordered. Are there any questions from members of the subcommittee? Question from Co-Chair West.
Thank you, Mr. Chairman. Could you go into detail on the new students that are eligible? What is there new eligibility in the first set of regs here?
And I do apologize. I am pinch hitting today for our general counsel who is sick, and I just found out late last night. So if I don't have an answer, I will get that to you later. And I apologize. I'm not extremely familiar with that, but we just do mirror the Pell regulations for the federal government because all the state aid in the state of Kentucky, as is with most states, is based on Pell eligibility. I don't think it's a major change by any means, but I can get you more details on that.
So in the summary, it stated, enlarged eligibility for non-citizens. And in another committee, we're working on some KHEAA stuff, maybe expanding that to others. And so I was just curious if we're now going to be expanding KHEAA eligibility to non-citizens. Mm-hmm. Is that what this is doing?
For non-citizens, I don't think it's a large expansion, and it isn't like it may sound like everybody who's a non-citizen is eligible.
Sure.
There may be a very small,
Targeted.
narrow subset of beyond what it is now.
I have a feeling he's getting ready to tell me.
Okay,
what's going on here.
good, thank you.
Sorry, it appears that some of these are territories of the United States. I'll check it out myself. Thank you.
Okay, I apologize. Thank you.
Are there any other questions or comments from the subcommittee? No further questions. Thank you. Please call the next regulation.
Office of the Attorney General, Department of Law, 40 KAR 2 150 with staff suggested amendment.
40 KR 2150 amends to delete language already in material incorporated by reference, update material incorporated by reference for clarity, consistency, and to comply with recent legislation, and delete the pre-need cremation authorization form. The staff amendment amends various sections to comply with KRS Chapter 13A.
Would you please identify yourselves for the record?
Christopher Thacker, Assistant Deputy Attorney General.
Steve Humphreys, Assistant Attorney General.
Thank you all for being here with us today. There is a staff amendment. Is there a motion for approval of the staff amendment? Without objection, it's so ordered. Are there any questions from members of the subcommittee? Seeing no questions, thank you. Please call the next regulation.
Thank you.
General Government Cabinet, Personnel Board, 101 KAR 1 325. This does not have additional amendments.
This regulation is being amended to set the mandatory probationary period for the job classifications of Public Safety Telecommunicator 3 and Public Safety Telecommunications Manager to a 12-month term, delete 8 positions that have been abolished, and add 7 classification name changes and 2 new classifications.
Please identify Please identify yourself for the record, sir.
Good morning. I'm Stafford Easterling, General Counsel, Personnel Board.
Thank you for being here. There are no amendments. Are there any questions from the members? No further questions. Thank you. Please call the next regulation.
Finance and Administration Cabinet, Kentucky Retirement Systems, 105 KAR 1 411 with staff suggested amendment. However, it does not look like we have anyone here from the agency. Therefore, this regulation has been deferred pursuant to 13A 300. Continuing on, Board of Pharmacy, 201 KAR 2 360, 2380E, and Ordinary, and 2450. All except for the emergency regulation have staff suggested amendments.
201 KR 2360 amends to authorize emergency departments to stock naloxone so it can be dispensed to patients treated in the emergency department before being discharged when the outpatient pharmacy is closed, establish requirements for a pharmacist supplying naloxone to an emergency department per a physician-approved protocol, and make KRS Chapter 13A changes. The staff amendment amends various sections to change references from naloxone to opioid antagonist and update the application form for consistency with Senate Bill 56 from the 2022 regular session, and amends sections to comply with KRS Chapter 13A. 201 KR 2380E amends to delete the list of specific conditions with board-authorized protocols and permit the board to establish provider-approved protocols as deemed appropriate by the board to permit a more rapid response to public health emergencies. 201 KR 2380, in the amended after comments version, amends to change the definition of prescriber to mean any Kentucky licensed physician or advanced practice nurse practitioner, add definitions for fully executed and protocol registry, update the protocol registry language and protocol procedures, add that a pharmacist not a party to a fully executed protocol shall not use the protocol, add that a pharmacist utilizing the protocol shall be employed by or contracted with the permit holder, require a fully executed protocol to be submitted to the board for inclusion in the protocol registry before use, add that a pharmacist in charge shall be responsible for submitting a fully executed protocol to the registry and for providing written notification to the board to remove a protocol from the registry no later than 30 days after discontinuing a protocol, and add a protocol review committee and establish its duties and composition. The staff amendment amends Section 1 to add a definition of protocol and amends sections to comply with KRS Chapter 13A. 201 KR 2450 establishes actions constituting unprofessional conduct by a pharmacy permit holder. The amended after comments version amends to add definitions for provision of pharmacy services and safe practices, clarify the list in Section 2 is not an exhaustive list of unprofessional conduct, delete essential from pharmacy services for clarity, add failing to appropriately train staff and pharmacy employees to the list of what is unprofessional conduct, delete habitually, Remove list of pharmacy responsibilities and add a reference to under state and federal laws and regulations. Add it as a violation to require pharmacists to operate a pharmacy with policies and procedures that deviate from safe practices. Add it as a violation to take disciplinary action or otherwise retaliate against a licensee or registrant that reports or refuses to operate a pharmacy that deviates from safe practices, or a pharmacy that deviates from state and federal law and regulations, and make other changes for clarity. The staff amendment amends sections to comply with KHEAA Chapter 13A and amends Section 1 to define a pharmacy permit holder.
Would you please identify yourselves for the record?
Yes, good morning. Chris Harlow, Executive Director.
Eden Davis, General Counsel.
Thank you so much for coming. We do have a speaker both for and against these regulations, but there are staff amendments. If I can get a motion.
Motion.
Without objection, so ordered. Are there any questions from the subcommittee? Senator Adams.
I'd like to hear from the speakers first before questions are called, if that's appropriate, Mr. Chairman.
Absolutely. Let's see. First, we have Mitzi Stoltz with the Kentucky Pharmacists Association. Please identify yourself for the record, please.
Good morning. My name is Misty Stutz. I am currently serving as the president of the Kentucky Pharmacists Association, and I also am the dean of the Sullivan University College of Pharmacy and Health Sciences. So we are here today to express our strong support for the amendments to the board authorized protocol regulation as submitted by the Kentucky Board of Pharmacy. These are needed to maintain extended access to quality care at pharmacies across our state and to allow for quick and efficient response to emerging public health challenges. In recent years, we have observed firsthand how new and unexpected health threats continue to emerge and impact our healthcare delivery system. To effectively respond to these challenges, our system of care, including that provided by pharmacists, should be agile. These amendments are vital in achieving this necessary agility. Since the initial promulgation of this regulation in 2017, the Board of Pharmacy has amended the regulation 3 times to ensure that physicians and other healthcare providers can effectively collaborate with pharmacists to offer patient care services for acute, self-limiting conditions. The regulatory burden associated with these numerous amendments is high, and moving amendments through the regulatory process takes time, reducing our ability to respond quickly when new public health challenges arise. While emergency regulations can be promulgated, not all public health matters rise to the level of imminent threat to public health, safety, and welfare, and yet can have devastating long-term impacts on the health of Kentuckians. In a recent study published in the Journal of General Internal Medicine, researchers found that primary care physicians would need 27 hours per day to provide guideline-recommended care to their patients. Pharmacists are highly educated and trained to collaborate with physicians and other allied healthcare providers through guideline-based protocol-driven care to help treat acute minor ailments and provide preventative health services. These services are in no way meant to replace primary care physicians, but to address gaps in care and public health threats in a timely fashion, working with and not opposed to our physician colleagues. All board-authorized protocols must be authorized and signed by a Kentucky licensed physician or nurse practitioner, and all documentation of care goes to both the signing provider and the patient's primary care provider if they have one. The increased utilization of protocols also serves as entry points to the healthcare system, allowing pharmacists to refer complex patients to physicians who may not otherwise have seen a provider. With 90% of Americans living within 5 miles of a pharmacy, pharmacists has long been recognized as vital in efforts to promote public health and welfare. Both the state and federal governments have relied upon pharmacists to expand access to care and save lives for decades. The regulation under consideration today was drafted by the Board of Pharmacy following a request by the Department of Medicaid Services regarding its needs to ensure members had access to Paxlovid for the treatment of COVID-19. The board responded by filing an emergency regulation that would allow a Paxlovid protocol to be developed and approved for use by collaborating physicians and pharmacists. This request came after pharmacists have worked diligently for the past 3 years to provide an estimated 42 million COVID tests, administer 2 out of every 3 COVID vaccinations, and save an estimated $450 billion in healthcare-related costs. This focus on providing patient care using a team-based approach has resulted in better patient health outcomes and saved state and federal resources. In eliminating the list of authorized conditions, the board has added language to the proposed amendment that would strengthen its oversight on this team-based approach to care. The amended regulation would establish a protocol review committee and a protocol registry. We fully support these changes. While we have implemented over 200 protocols across the Commonwealth and are not aware of any complaints or cases concerning this care since the inception over 5 years ago, these measures will further strengthen the safety of our patients and assure the highest level of care. We applaud the General League's Assembly's recognition of the importance of pharmacists in providing access to care to serve our communities. Pharmacists are highly educated and trusted healthcare professionals that have long been seen as the first point of contact for patients seeking advice and care for self-limiting conditions and preventative care. Successful implementation of this regulation will allow us to continue to provide this care, as well as address emerging public health needs in a timely manner. This regulation will expand the reach of physicians and other allied healthcare providers and increase access points to the healthcare system that patients may otherwise not have. With this in mind, we respectfully ask this committee to allow the regulation to proceed as filed without any significant changes. Thank you for your time and consideration.
Thank you for your testimony, Mrs. Stoltz. We also have a speaker with the Kentucky Medical Association, if you'll come up. Please introduce yourself for the record.
Good morning, Mr. Chairman and members of the subcommittee. My name is Corey Meadows, and I am Deputy Executive Vice President of the Kentucky Medical Association. I also head up our advocacy department. I appreciate the opportunity to offer comments this morning on this regulation. My testimony will be an abbreviated version of written comments that KMA submitted to the Board of Pharmacy during the comment period. At the outset, I want to state that KMA is opposed to the concept of board-authorized protocols overall. And we believe that the regulation in any form is not sound health policy. We believe that any protocols that are approved by the Board of Pharmacy should be approved by the General Assembly like they have been done in the past before this regulation was done in 2017. But since the regulation pertaining to the board-authorized protocols is already in existence, I will focus my comments and concerns regarding what the emergency regulation is already doing and what the ordinary regulation is proposing to do. And they are significant concerns. Number one, the emergency and ordinary regulations are unnecessary and a dramatic shift away from previous KMA and Board of Pharmacy discussions. This regulation was originally proposed and adopted in 2017, as I mentioned. It was finalized after detailed discussions between the KMA and the board regarding quality and patient safety in a variety of situations. Based on those discussions, some issues were addressed. Unfortunately, just a few years later, the board is now proposing revisions to the regulation that would remove those safeguards. Such a result would be especially disappointing considering the changes are unnecessary. The board's stated reason for the amendment is to, quote, allow pharmacists to play a more critical role in public health and to respond immediately to public health needs without the delay of going through the rule-making process. This rationale ignores the fact that a process already exists for the board to respond to the public health emergencies. It's called the emergency regulation process, which ironically the board used in relation to this amendment. And they also used it throughout the recent public health emergency. Therefore, if it worked for this amendment, why couldn't the emergency regulation process work for quickly responding to future public health emergencies? Furthermore, it begs the question, why would the board want to avoid the rule-making process to begin with? Number two, the amendment lacks sufficient parameters and transparency. Up until the emergency regulation went into effect, the regulation contained a specific list of conditions for which the board could develop a protocol. By having the list in the regulation, the board was required to open the regulation and go through the regulatory process if they wanted to add new conditions to be treated through these protocols. However, the emergency regulation removed that list, and the ordinary regulation proposes to permanently remove that list from the regulation, which before the emergency regulation there were 17 conditions that were listed. Instead of the list, the board now states that protocols can be developed for, quote, acute self-limiting conditions and other minor ailments, preventive health services, and disease state monitoring and management as deemed appropriate by the board, end quote. This opens the door wide open. Without listing the types of conditions and disease states, the amendment allows the board to develop and utilize protocols for a vast number of medical conditions without opening the regulation. In other words, the board has a blank check regarding prescriber protocols, allowing the development and implementation of protocols without notice or comment to the legislature, relevant advocacy groups, or the public. This action would effectively bypass you, the Kentucky General Assembly, as well as the regulatory approval process established by 13A, and run counter to an open and transparent rulemaking process, which is the hallmark of good government. Now, I know there were some staff changes. I have not seen those, and there was some mention about Chapter 13A. If some of this has been corrected, that will be certainly a positive step. But if it has not, this regulation lacks transparency. As a result, the board's proposed approach could have significant public health implications. Any use of protocols should be limited, evaluated on a condition-by-condition basis, and specifically stated in statute by you. Number 3, the proposed amendment to the regulation removes necessary education and training requirements. Prior to the emergency regulation, the language of the regulation, specifically Section 4, required subject matter education and training requirements for pharmacists participating in a protocol. KMA believes such education and training is a wise and necessary policy. Reason being, under these protocols, pharmacists can treat complex conditions and disease states, including involvement with tuberculosis, opioid use disorder, and HIV. These are serious conditions in which they would be playing a role. If the proposed amendment is adopted, the number of conditions and disease states addressed by these protocols would likely increase in number. Given the potential increase, the board should be looking to expand current education and training requirements. But inexplicably, however, the proposed amendment takes the opposite approach and eliminates all subject matter education and training requirements for pharmacists participating in the protocol. The removal of education and training should be reconsidered to ensure quality care and patient safety. And I do want to say that based upon the changes that were made, we believe that they are woefully insufficient. Number one, the protocol committee that has been established, the way that we read the changes, that committee would focus on procedural requirements of the protocols, not substantive a review of the protocol. In other words, we do not read that this protocol committee could veto a particular condition from being treated with a board-authorized protocol. So the way we read it, they're just checking the procedural boxes to make sure everything is in order. Even if they had veto power or some sort of a substantive overview of new protocols, on that protocol committee, there are 4 pharmacists, 1 physician. So the idea that this is true collaboration, I think falls short of that, because clearly the physician would be outnumbered even if they had some sort of authority over the protocol. We believe that at the end of the day, the Board of Pharmacy can still do what they want to. Also, through this process, they mention that there is still a process for the public to comment regarding the development of these. Quite frankly, I don't know where that language is. If there's a public comment process noted in there, it escaped me. And so our concerns still remain that this is not a transparent process and needs to run through what we're doing here today to ensure that on your behalf and your constituents' behalf that public health is being protected. And with that, I'll stop and happy to answer any questions that you all have.
Before we get into questions, I'll keep you both at the table. And thank you for your testimony, Mr. Meadows. I would like to give the agency an opportunity to respond.
Okay, thank you. I will address some of the comments, and I'll turn it over to our counsel to address some of the rulemaking processes that were mentioned. But the mission of the Kentucky Board of Pharmacy, first and foremost, is public and patient safety, and that's what we're focused on. We do care about the health of Kentuckians and access to care, to evidence-based treatment, current clinical guidelines, and quite frankly, the 201 KR 380 as it's currently written is insufficient oversight by the Board of Pharmacy. So we needed these necessary changes to ensure we had the authority to make sure that pharmacists were acting within their current scope of practice. The purpose of the Protocol Review Committee is both to ensure compliance and to make sure that the protocols are appropriate, and it was meant to be collaborative. I did consult with both Board of Nursing and Board of Medical Licensure to get comments, and they were okay with the changes. And I wanted to ensure that they were involved. Regarding training, I think it's important to know that the expectation of the Board of Pharmacy is that pharmacists are properly educated and trained before implementing any protocol. We have the authority to act based on a standard of care approach, and we will act on the standard of care approach of the pharmacists acting outside of their education and training. The protocols are specific regarding the training. It doesn't need to be part of the regulation because it's part of the protocol, and the part of the Protocol Review Committee is to ensure compliance with the current practice guidelines. And I will turn it over to our General Counsel for.
So there was some mention of. Thank you. There was some mention of attempting to bypass the rulemaking process. That certainly was not the intent of this regulation. The intent was to be able to respond nimbly to public health situations that would not necessarily qualify for an emergency regulation. As you all know, the rulemaking process takes time. I mean, at a minimum, usually we're looking at a 6-month period. And so if there were a threat to public health that didn't rise to the level of an imminent risk to all citizens of the Commonwealth, then we might not qualify to be able to promulgate an emergency regulation. And so having this where it's open-ended, it allows us to be able to respond to those conditions and to do so quickly in partnership with physicians to be able to assure that the health of the citizens of the Commonwealth is paramount.
Thank you. I know we have several members with questions. First will be Co-Chair West.
Thank you, Mr. Chairman. My question is for the board first, and I'm going to have you guys give me the answer to this question. And then, Mr. Meadows, if you would give me your version of the answer to that question. So, and I'm going to kind of throw you a softball example. So an imminent threat, I want you to give me an example, a real-life example of where this would come into play. I'm assuming COVID would be a good example that we could start with. So give me the picture of what that looks like now, the protocols, review process, and then after this proposed reg theoretically goes through, then what would that look like at that point?
Well, as far as an emergency regulation or?
Yeah, so for instance, in the state's overall response to COVID, the Board of Pharmacy, the medications that flow through the process to treat COVID, what does that look like now? And after this reg, if this reg were to proceed forward, what would that process look like after the fact?
Okay, so you're asking specifically about the process of the creation of the protocol if it's under an emergency reg versus if it's not?
Correct.
Okay.
And to further clarify, we already have an emergency process.
Right.
So this changes that process, I'm understanding, a bit. So explain.
Right.
Help me understand.
So currently, under KRS 13A, we are authorized to promulgate an emergency regulation to respond to an imminent threat to public health and safety. So obviously, you're exactly right. COVID is a situation where we did see that threat. In fact, we saw a national declaration of emergency. And so whenever we approved the emergency regulation here, that was at the request of the Cabinet for Health and Family Services needing to be able to provide Medicaid patients with Paxlovid. Paxlovid obviously being a therapeutic for COVID-19. So that's just a situation how we utilize this in the emergency setting in a situation that would qualify as an imminent public health emergency. Now, there could potentially be maybe a community-wide spread of something like measles, something that's only in a specific portion of the state. I'm trying to think other examples of something that might be.
Most recently, both alcohol use disorder and opioid use disorder, those would not rise to the level of an emergency regulation, but we've effectively implemented those protocols. Now, opioid use disorder was part of the original authorized conditions, and then we ended up adding alcohol use disorder at a later time. So those are examples where we wouldn't necessarily need to file an emergency regulation, but it's an authorized condition that's really necessary for the people of Kentucky.
In response, I think they very articulately laid out for you the process that currently exists and why it currently works. We're not sure why we have to have a middle ground. If there's an imminent threat, I believe the words were used, then the emergency regulation process exists. I think we can all agree during the COVID pandemic, there were no shortages of emergency regs to respond to that public health crisis. Anything that falls outside of the emergency is not an emergency and can be addressed by the ordinary reg process. But essentially what we're establishing here is a third option for the Board of Pharmacy to utilize that unfortunately, as I mentioned, takes away education and training and bypasses you. And that's the essence, as I mentioned, of transparency and good government. So we do not agree that there should be a third option. We think there should be the emergency reg process as well as the ordinary reg process.
Next question is Senator Rocky Adams.
Thank you, Mr. Chairman. It was stated that, I guess I want some clarification on what does that mean that you wouldn't qualify for an E-reg? Give me a scenario in which you wouldn't qualify for an E-reg.
Well, I think if there was for example, like let's say there was an outbreak of a specific condition, but it was limited to a certain community. It maybe didn't impact all of the citizens of the Commonwealth. I don't know if that would necessarily qualify for an emergency regulation. I mean, it's a fairly, I know working with Governor Beshear's staff, it's a pretty hefty burden that they want us to be able to exemplify that we have a true emergency. And with COVID-19, of course, it's easy. It impacted everybody. We have a national declaration, but there are situations where we might not have that. That's an extreme example. There are situations where we might have an outbreak of something, and pharmacists will not be able to participate in treatment if we don't qualify for an emergency regulation until potentially 6 to 8 months later.
So you're saying we could have a specific outbreak of something and you wouldn't qualify for an E-reg. That seems like a hypothetical that would never exist, because if there's an outbreak on something, I think that there would be an immediate engagement on that public health crisis through the E-reg process. So I'm struggling with your example. But second of all, I remember that bill where the statute where we actually laid out those protocols. I'm aging myself now. What was it, 17 or 18? I forget. Mm-hmm. And that was a very challenging time, because we were allowing, through a leap of faith, for pharmacists to participate, kind of one-on-one with that patient by putting forth a very specific list of conditions that we could develop protocols around. And that was not taken lightly, and public health was really at the forefront of a lot of these members' concerns with that bill. And so I feel as if this is we've kind of jumped the shark on that transparency and that collaboration on that original process in 2017. And so Mr. Chairman, I have some concerns about moving this forward because I don't think that we have a problem that needs to be solved right now. Thank you.
Thank you, Senator. So being from the pharmacy sector, I know we've had conversations on this, and I do see a need. I also think it's important to recognize the fact that, in our discussions with staff that, I asked, specifically, did you all have the authority to do this? And they saw no issue. That being said, I am just but one member, and my co-chair also has some comments.
Thank you, Mr. Chairman. Circling back a little bit, I'm going to read from 13A on the requirements to have an emergency reg. So, emergency administrative regulation is one that A, and then there's a list, 1, 2, 3, 4. Number 4 is protect human health and the environment. You could drive a truck through that. That's a pretty expansive reason to have an emergency reg. And just because there's an outbreak of something in a certain part of the state doesn't mean you can't have an emergency reg. I think you could have an outbreak in a certain area and it would still rise to an imminent threat to allow for an emergency reg. And the comment about the administration sees that as a heavy burden to meet that status, to have an administrative reg. We got a reg coming up where the administration is saying his press release is good enough. It's met the burden to have an emergency reg. So whenever we talk about medical related issues and the KHEAA comes forward, I tend to listen. This is a very, very important issue. And to me, we're forming an intermediate step that takes away some transparency. And these new protocols would not then have to come before this committee. There would be that intermediate step. And so at the very least, I would ask for a deferral of this regulation so it could be discussed more and go through the process a little bit more and go back and forth. So that is my request to the board at this time, Mr. Chairman.
Would the board agree to the deferral?
Absolutely, yes.
Thank you. Yes, Senator.
If we defer, what does that look like? Is it does the Board of Pharmacy get together with the KMA and they have conversations? What do we anticipate this deferral looking like?
It sounds as if there's some unresolved issues on both sides. As for what the agency does from there will be up to them. I do look forward to working on this issue, and if there's some resolution we can come to. With that being said, is there a motion for deferral? Thank you. Without objection, so ordered. Thank you all for coming. Please call the next regulation.
Board of Dentistry, 201 KAR 8016, 520, 571, 601, all with staff suggested amendments.
(201) KR 8016 amends to clarify initial registration and renewal requirements and update forms. 201 KR 8520 amends to create a fee schedule for the registration of mobile dental facilities, including a $150 registration fee and a biennial $75 renewal fee, and the penalty fees for late renewal that range from $150 to $225. 201KR 8571 amends to clarify registration and expanded duty requirements for dental assistants and update the delegated duties list. The staff amendments for these regulations all make changes to comply with KRS Chapter 13A. Additionally, the staff amendment for 201KR 8571 amends the relates to and statutory authority paragraphs to delete references to a repealed statute.
201-8601 establishes requirements for the issuance and renewal of registrations for mobile dental facilities and portable dental units. The staff suggested amendment amends various sections to comply with the drafting and formatting requirements of KRS Chapter 13A and make technical changes.
Welcome. Well, please identify yourself for the record, please.
Good morning, Mr. Chairman, members of the committee. I am Jeff Allen, Executive Director of the Board of Dentistry.
Good morning. I'm Ann Tyler Morgan, legal counsel for the board.
Welcome. Thank you all for coming. There are staff amendments. There's a motion for staff amendments. Without objection, so ordered. Are there any questions from the committee members? If no further questions, please call the next regulation. Thank you all for coming.
Thank you.
Board of Medical Licensure 201 KAR 9470 without additional amendments.
201KR 9470 amends pursuant to Senate Bill 173 from the 2022 regular session to allow for the medical order of scope of treatment form to be transmitted in print or electronic form and in languages other than in English, and update the most form and add a Spanish most form.
Would you please identify yourself for the record?
Good morning, Leanne Diakoff, General Counsel for the Board of Medical Licensure.
Thank you. There are no amendments to this regulation. If there's any questions for the members? Seeing none, thank you. Please call the next regulation.
Thank you.
Board of Nursing 201 KAR 2370 with staff suggested amendment.
201KR 2370 amends to consolidate online and paper application forms and update forms for clarity, electronic submission, and to make formatting and font-related changes, with the substantive content being left generally the same. The staff amendment amends Section 2 to restore the previous language of an application for licensure by endorsement, lapsing within 1 year from the date of the application form being filed with the board office, and amends Section 1 to comply with KRS Chapter 13A.
Would you please identify yourselves for the record?
Yes, Kelly Jenkins, the Executive Director at the Board of Nursing.
Yes, good morning, Jeff Prather, General Counsel, Board of Nursing.
Thank you so much. There is a staff amendment. If I can get a motion for approval.
Motion.
Without objection, so ordered. Are there any questions from the committee? Without no further questions, thank you. Please call the next regulation.
Thank you.
Board of Social Work 201 KAR 23051 emergency. This does not have additional amendments.
201KR 23051E establishes a definition of licensee, the requirements for renewal, termination, and reinstatement, and the application for renewal form incorporated by reference.
Would you please identify yourself for the record?
Mark Kelly, Executive Director of the Board of Social Work.
Thank you, sir. There are no amendments. Are there any questions from the members? No questions. Thank you. Please call the next regulation.
Tourism, Arts, and Heritage Cabinet, Department of Fish and Wildlife Resources 301 KAR 219, 221, and 228. Both 221 and 228 have staff suggested amendments.
3012-219 repeals 3012-224 and 2-226 because the amendments to 301 KR 2-221 include updated sections to address the subject matter contained in those regulations. 301-221 is being amended to change the closing date for falconry waterfowl season to the last Sunday in February for all species of waterfowl, remove reference to conservation order light geese seasons, and make technical corrections. 301-228 is being amended to remove the requirements of metal leg tags on harvested cranes. The staff suggested amendments to these regulations amends various sections to comply with drafting requirements of KRS Chapter 13A and make technical changes.
Would you please identify yourselves for the record?
Jenny Gilbert, Legislative Liaison for the Office of the Commissioner.
Stephen Field, Staff Attorney.
Thank you all for coming. There are staff amendments. If I can get a motion.
Motion.
Is there a second? Without objection, so ordered. Are there any questions from the subcommittee? Well, we see you all a lot, so I'm sure next time, right? If there are no further questions, thank you. Please call the next reg.
Thank you all.
Justice and Public Safety Cabinet, Office of the Secretary, 500 KAR 16010. This also has a staff suggested amendment.
This regulation establishes the definitions, standards, and criteria governing the disbursement of money from the Elder and Vulnerable Victims Trust Fund. The staff suggested amendment amends various sections to comply with the drafting and formatting requirements of KRS Chapter 13A.
Would you please identify yourselves for the record?
Good morning. Alicia Mahoney, Executive Staff Advisor.
Good morning. Nathan Goins, Legal Counsel for the Cabinet.
Thank you. There is a staff amendment. There's a motion.
Motion.
Without objection, so ordered. Are there any questions from the subcommittee? Okay, no further questions. Thank you. Please call the next regulation.
Education and Labor Cabinet, Department of Workplace Standards, 803 KAR 1081. This does not have additional amendments.
This regulation amends to clarify when and how a tip pool may be used in accordance with Senate Bill 180.
Would you please identify yourself for the record?
John Galian, General Counsel for the Department of Workplace Standards.
Thank you. There are no amendments. Are there any questions from any of the members? No further questions. Thank you. Please call the next reg.
Public Protection Cabinet, Department of Insurance, 806 KAR 17280 with a staff suggested amendment and an agency amendment, and 806 KAR 17290 with a staff suggested amendment.
806-17280 amends the requirements for internal appeals of a step therapy exception denial and establishes a reporting process for insurers and pharmacy benefit managers to annually report the total number of step therapy exceptions denied or approved and what category of services were denied or approved, and make technical changes. The staff suggested amendment amends various sections to comply with the drafting requirements of KRS Chapter 13A, add clarifying language and make technical changes, and amends the material incorporated by reference to comply with the statutory requirements and make technical changes. The agency amendment amends sections 4 and 9 to add clarifying language and make technical changes. 806-17290 is being amended to subject step therapy exception denials and step therapy internal appeal denials to the external review process of an independent review entity and make changes to material incorporated by reference. The staff suggested amendment amends section 12 and the material incorporated by reference to make technical changes.
Would you please identify yourselves for the record?
Abigail Gall, Executive Advisor, Department of Insurance.
Sean Orm, Executive Advisor, Department of Insurance.
Thank you all for coming today. There are staff amendments. Is there a motion?
Motion.
Without objection, so ordered. There is also an agency amendment. Is there any discussion on the agency amendment? Is there a motion for approval?
Motion.
Without objection, it's so ordered. Are there any questions from any of the members? Seeing no further questions, thank you. Please call the next regulation.
Thank you.
Cabinet for Health and Family Services, Department for Medicaid Services, 907 KAR 1680 with staff suggested amendment, 3010 without additional amendments, and 907-20050 with staff suggested amendment.
907 KR 1680 amends to make participation permissive and allow reimbursement for certain providers regardless of provider program participation, and amends sections to comply with KRS Chapter 13A. 907 KR 3010 amends to clarify that only providers enrolled in the Vaccines for Children program cannot receive reimbursement for the cost of the vaccine if it is readily available in the enrolled provider's facility, allow for additional evaluation and management codes to be utilized by providers over the course of a year to allow evaluation and management services to comply with the recent Centers for Medicare and Medicaid Services reorganization of evaluation and management codes, and update the supplemental payment schedule to reflect current practice and federal approval by becoming an annual and not a quarterly payment. 907 KR 20050 amends to incorporate changes made by House Bill 7 from the 2022 regular session. require DMS to collaborate with the KHEAA and academic medical centers to institute an annual training process and establish a comprehensive form to assist with the use of presumptive eligibility within the qualified hospital setting, create a form and process for informing DMS of a presumptive eligibility decision within 5 days, and clarify expected privacy standards for transfer of documents by qualified hospitals and DMS. The staff amendment amends to create a new Section 9, incorporating by reference the presumptive eligibility hospital patient information form, and amends Section 8 to insert web links, and amends to comply with KHEAA Chapter 13A.
Thank you. Would you please identify yourself for the record, please?
Good morning. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services.
Good morning. Jonathan Scott, Reg Coordinator, DMS.
There are staff amendments. Is there a motion for approval of the staff amendments? Without objection, so ordered. Are there any questions from the members of the subcommittee? Seeing no further questions, thank you. Please call the next regulation.
Office for Children with Special Health Care Needs, 911 KAR 1060, 085, and 090, all with staff suggested amendments.
911 KR 1060 amends to remove the provisional status process and update material incorporated by reference. 911 KR 1085 amends to reduce the time frame from 7 days to 48 hours for returning a form when there is evidence of hearing loss. Update the American Academy of Audiology's guidance document. Include an option for audiological centers to notify the office of a name change with the modification form, and update references to change commission to office. 911 KR 1090 establishes requirements for requesting an appeal by administrative hearing through the Office of the Ombudsman and Administrative Review. The staff amendments for 911 KR 1060, 85, and 90 amend various sections to comply with KRS Chapter 13A.
Would you please identify yourself for the record?
Good morning. I'm Ivy Alexander, Executive Director at the Office for Children with Special Health Care Needs.
Emily Allen, Procedures Development Specialist, Office for Children with Special Health Care Needs.
Thank you all for coming. There are staff amendments. Is there a motion for approval of the staff amendments?
Second.
Without objection, so ordered. Are there any questions from the committee members? Representative Frazier.
I don't have a question. I just have a comment. As an audiologist, I want to thank you for bringing these forward and for everything that you do. You are truly a model for the rest of the nation on this, so it's nice to be a small part of it. Thank you.
Thank you.
There are no more questions or comments. Thank you all for coming. Please call the next regulation.
Thank you.
Department for Community-Based Services, 921 KAR 2006, 500, 510, and 520. These do not have additional amendments.
921 KR 2006 amends to update outdated definitions and citations, update program names consistent with other regulations, eliminate administrative barriers requiring verifying school attendance for children, and remove deprivation requirements that have kept two-parent families from being eligible for KTAP. 921 KR 2500 amends to increase the maximum benefits for FAST services provided with temporary assistance for needy families block grant funds, and update companion program names. 921 KR 2510 amends to increase the maximum benefit for RIP services provided with federal temporary assistance for needy families block grant funds to eligible Kentucky families who need to relocate to accept or maintain employment, escape a domestic violence situation, or prevent homelessness. Update other program names for consistency with other regulations in process, and update the application for relocation assistance to include information pertaining to the housing crisis.
921-2520 is being amended to increase the maximum benefit for WIN services provided with temporary assistance for needy families, block grant funds, update program names for consistency with other administrative regulations, and update the material incorporated by reference to clarify instructions and add agency contact information.
Would you please identify yourself for the record?
Good morning. My name is Laura Began. I'm the Regulation Coordinator for the Department for Community-Based Services.
Thank you for coming today. There are no amendments. Are there any questions or comments from members? Seeing no comments or questions, thank you so much.
Thank you.
So we're going to jump back. We did have an agency that just came in earlier. We're going to do Finance and Administration Cabinet.
It's Kentucky Retirement Systems, 105 KAR 1411 with a staff suggested amendment.
This regulation establishes the procedures for the Kentucky Public Pensions Authority to administer the health and hospital insurance benefits provided to retirees. The staff amendment amends Section 1 to add a definition for wellness or well-being promise, amends Section 10 to clarify procedures when enrollment is not mandatory, and amends various sections to comply with KRS Chapter 13A.
Would you please identify yourself for the record?
Carrie Bash, Staff Attorney Supervisor, Kentucky Public Pensions Authority.
Jessica Bobian, Policy Specialist with KPPA.
Thank you all for coming today. There is a staff amendment. Is there a motion for approval of the staff amendment? Without objection, so ordered. Are there any questions or comments from the committee members? Thank you for coming.
Thank you.
So now we're going to get into other business. And I think several of us have
It's under Cabinet for Health and Family Services, Department for Medicaid Services. 907 KAR 1026 Emergency and Ordinary, 907 KAR 1038 Emergency and Ordinary, and 632 Emergency and Ordinary.
907-1026, an emergency, amends the Kentucky Medicaid program dental provisions to make technical corrections, remove age limits on many applicable services, update the term direct provider contact to direct provider interaction to include telehealth, delete the definition for and references to the term locum tenens dentist, remove the limit of 12 dental visits per year, establish additional requirements pertaining to orthodontics and dental space maintainers, expand endodontic, periodontic coverage, and establish that dental pain may include a hospital call, ambulatory surgical center call, or extended care facility call. 907-1038, an emergency, amends the Kentucky Medicaid program hearing provisions to remove the age limit of 21 and the physician referral requirement. 907-1632, an emergency, amends the Kentucky Medicaid program vision provisions to make technical corrections and remove the age limit of 21.
Thank you all for coming today. Please introduce yourselves for the record.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services.
Jonathan Scott, Reg Coordinator at DMS.
Thank you. So I know myself and Co-Chair West, we've received several members of this committee have reached out to us, several providers in our district. I guess there's been quite a bit of confusion about some of these regulations and why they're deemed to be an emergency. Sorry.
I was straining a little bit.
Gotcha. So yeah, there's been quite a bit of confusion on why, these regulations need to have an emergency with them. I do appreciate what you do and what your cabinet does. Being in the realm myself, I fully understand and for helping patients across Kentucky. I know the providers that I've spoken with, there's been concerns that perhaps the communication between these e-regs going into effect and the delayed implementation of CMS has been confusing to both them, the MCOs, and the patients themselves. I had one question, and I'll turn it over to some of the other members. But when you all were looking at these changes, were you communicating with the MCOs to make sure that patients were aware and educated on, when they would be eligible for these benefits?
I will agree that the communication has not been optimal. It has not been what it should have been. Once the regulations have been filed, we have been into discussions with providers, have been contacting the department, particularly the dental community. We've heard from several oral surgeons in addition to the dentist community, and we have been discussing some of the changes that we're making to make sure that we can roll them out appropriately. There has been a little bit of confusion, but working with our technical advisory committee, our dental technical advisory committee, and some of the providers in the community, we're clearing up some of those communications and making sure that we're moving forward in a way that promotes the health and safety of our members.
Okay, are there any, thank you, by the way. Are there any questions or comments from other members? Go ahead. Co-Chairman West.
Thank you, Mr. Chairman. First question is it safe to say this is a pretty large expansion of services in this space? Is that correct?
I wouldn't necessarily categorize it as a large expansion. Several states do cover the same services in their dental program. What I would say is that we are doing this in an effort to offset future costs. We know that poor dental care is associated with heart disease, preterm deliveries. We know that the cost of caring for little infants that are in the neonatal intensive care unit is extremely expensive. And if we can allow just another dental cleaning, some preventive services for our pregnant population, we believe that's going to offset some of those costs. Hearing aids, for example, there is studies have been conducted that show that within a year of getting a hearing aid with hearing loss, that the chance of developing dementia decreases by 18%. So, in addition to helping our population with improve their health care status, the other thing that we are focusing on is we know that public health emergency is expiring due to COVID, is expiring in May. We do know that we have several individuals that will be exiting the Medicaid program because during the public health emergency, we could not discontinue anyone from the Medicaid program unless they passed away, they moved out of state, or they requested to be disenrolled. So what the other piece of this is, the expansion, is some of those individuals that will be exiting, if we can catch them beforehand, if they need glasses, if they need hearing aids, or some dental work. We want to give them the tools to be successful after they exit the Medicaid program, so the chances of them obtaining employment that allows them to either get private health insurance or commercial insurance or get a product on the exchange will allow them to be successful after they exit the program, and the chances of them coming back in would be minimal.
If I could continue, Mr. Chairman. So what is the approximate cost of this?
I believe we have anticipated initially about $89 million, and that is both state and federal funds. Going forward, we anticipate some of those costs to be offset by reduced emergency room utilization. Currently, we pay over $9 million a year for adult dental services conducted or performed in the emergency room. We believe some of those costs will be offset. And again, going back to the dementia, if we can prevent individuals from developing dementia early on, we're going to offset some of those costs in the future. So we believe it is an investment in the future.
Did you all present this to the Medicaid Oversight Committee in November? Does that sound? November 10th?
I would have to go back and double check. I can't recall right now.
Okay. So neither one of you were at that meeting before the Medicaid Oversight and Advisory Committee to present, or representative of the cabinet?
I would have to go back and just double check the minutes. I know that we have been in discussions with the Medicaid Advisory Council since the regulations have been filed. We have also had several, I think, very productive discussions with the Dental Technical Advisory Council. We have had some recommendations from the Optometry Technical Advisory Council. Their recommendations center on, of course, medical necessity and quality of glasses. If you look at the regulation, you'll see that frames are limited to $50. I think my last pair of glasses that I bought cost over $700, so $50 for a pair of frames is you can imagine what the quality of those frames would be. So we are having discussions, and again, I think the communication could have been much better. But now that we're having these communications, we're not only talking about the services that we're hoping to deliver now, we're also talking about specific reimbursements. I know one of the biggest complaints from our provider community is reimbursement. So instead of looking at big, broad, sweeping, across the board change in reimbursement, we are looking at very specific codes specifically related to preventive. We have also discussed with their managed care organizations, and they have agreed to increase their costs to the Medicaid fee schedule.
So during this process, have there been any legislators that objected to the way these regulations were proceeding and the implementation? So did you have any experience in any other committees as to, did anyone else object to the way this was being handled, or?
Not to me. I think that on some of the committee meetings, there was an expression, for example, last week, this week, sorry, my days are running together, an expression of us being the Department for Medicaid Services, moving forward with the regulations without input from some of the General Assembly.
That's my understanding as a member of this committee, that other members have expressed clear objections, not in essence to the reg itself or what it's attempting to do, but the idea. I believe a lot of this money came from savings associated with SB 50 and the PBM, Senator Wise's bill, and I think the general idea was we want to say and where this money flows to. And to piggyback on what you were saying, that we hear complaints, pretty consistent complaints, that you can't find providers now to provide the services because the reimbursement rates are too low. So we should take a deep dive, maybe look at that first before we do this wide expansion. And that's what I'm hearing on my side. But I'll hold off for right now, and I think we have questions.
Senator Rocky Adams.
Thank you, Mr. Chairman, and I'm just going to echo what Chairman West said. Most of the feedback that I've gotten on this Medicaid expansion has been from the provider community. You know, they're struggling now with these low reimbursement rates, and they said, you know, we don't even want to take Medicaid patients anymore because it's just we're not adequately compensated for the care that we're providing. So I'll just echo those sentiments that looking at expanding those reimbursement rates for our current providers rather than expanding the what is allowable, I think is maybe a good place to start. Thank you, Mr. Chairman.
Thank you, Senator. And I'll echo those comments as well. You know, Eastern Kentucky, where I'm from, you know, in preparation of the day, I reached out to a lot of my dental friends, and you know, if you look at the statistics, yes, you can cite that 75%. Are accepting Medicaid, but most of them are not accepting new programs. They're breaking even at best, in most cases losing money. It's a loss leader in some areas. Transportation is a major concern in Eastern Kentucky as well, across the state really, and so we are essentially generating healthcare deserts. I talked to some optometrists, and while they probably participate more so than anybody else, I guess there are concerns, and you brought some up dealing with the lenses. I know on the contact lenses, they're only eligible, I think, for like one for each eye every year, the hard ones, and it's just not really ideal for patient care. And then if you look at the reimbursement rates when you're looking at the rest of the market on your Medicaid rates versus your commercial and Medicare rates, they're significantly lower. I believe I was cited. I believe rates have not been increased in over 15 years in dental. I'd wager farther than that. So I'll echo my colleagues' position that we support. I won't say support, but we understand what you're trying to do. It might be a better way of using this money to get there. Because again, you can expand coverage, but if you don't have a provider that's going to accept it, it's a moot point. I believe our Representative Bridges had a question.
Thank you, Mr. Chair. There's a number of issues and questions I have. You stated that it's not a great expansion, but you said the cost is $89 million. I will tell you, that's a great expansion. I fight bills asking for a few $100,000 for certain really needed items. And this falls into what I think is appropriations of funds. You don't have that authority. Just flat out, that is a General Assembly. Now, you can call it reappropriation of funds, but reappropriating is appropriating funds. And while there are some good intentions here, we've talked about reimbursements. I think in lower population areas, there will be those that will refuse to offer this service because the reimbursements have not been adjusted also. So I've really got some problems with this, Mr. Chair. Thank you.
Let's see, I believe Representative Frazier Gordon.
Hi, thank you for being here today. And as a provider that already participates in the hearing program, and I do it because I have a heart for children, and I know how important it is, and I do totally applaud the stats that you have recited regarding prevention of dementia and the importance of hearing at all ages. So I'm very supportive of that. But just as an example of how things are in practice and what you're asking a provider to do, right now the fee schedule for a hearing aid is $800 per device. So I am asked to purchase that device, have it set on my accounts receivable, send in a copy of that receipt with my claim while I'm waiting for it to get approved. Then, after weeks of resubmissions, I finally get it approved. I then have to contact the patient, get the patient in, and then I cannot submit it for payment until after the patient is fitted. So that device has been sitting on my accounts receivable for months. And then I have to wait another couple of months before I actually receive payment. So I go in the hole every time I do it, but I do it because I have a heart for children, and I know how important it is. So those are just things that need to be worked out, and I think it's just another example of maybe it's the cart before the horse. It's a good initiative, but it's just we need to be thoughtful in how we're rolling it out and that our providers are taken care of appropriately. So that's the only comment I have, Mr. Chairman.
Co-Chair West.
Thank you, Mr. Chairman. A couple quick questions. Before these were promulgated, did you all reach out to providers and kind of ask their opinion before you proceeded forward with these regs?
So the Department for Medicaid Services has approximately 22 technical advisory committees. Those committees hold meetings sometimes every other month, sometimes every quarter. In most meetings, we do talk about specific policies, and we ask for input regarding policies that we can make to improve access, to improve the delivery of services. Most often, the recommendations that we get are centered around reimbursement or administrative procedures. So we have asked for input. So while they have provided some input on that when we promulgated the regulations, the technical advisory committees now, the dental specifically led by Dr. Brabowski, are digging into the policies. Now they're actually looking at ways to make all of these services work. They're looking at ways to improve the health status of the state of Kentucky by focusing on preventive oral health. So we're having some great conversations right now. I'm glad we're having them. I wish we could have had some of these prior to, but we're having them now, and I think it's very important to drive this program forward.
So in the process, did you all check, is there budget language directing the savings from Senate Bill 50 where that should go to? Do you know?
I would have to go back and double check, but I'm not sure that there's specific budget language saying where the savings from Senate Bill 50 should be allocated.
Thank you. So under 13A, if you're going to do an emergency reg, you have to provide documentary evidence. What documentary evidence did the cabinet provide to move this reg forward and show that there was an immediate threat to public health, or that it should have an emergency status?
Well, we believe that improving the health status of individuals through the vision, hearing, and dental programs are very important. For example, again, going back to poor oral health in pregnant women resulting in preterm deliveries. Poor oral health contributing to heart disease, diabetes, things that we know are killing individuals in the Commonwealth. We think it's very important to be able to try to identify those procedures up front, do what we can to prevent those costs and those health diseases, those health care statuses from being worse in the future for our adult population.
Just to clarify further, I don't think that was my question. My question was, what documentary evidence was provided to show that this is an emergency by the cabinet?
As I recall, we submitted documentary evidence to show that we had to begin the services on January the 1st of 2023.
apparently, I may or may not have bad information. I don't know, but the information I have here shows that the evidence used to show that legislative intent was the governor's press release. So that was the documentary evidence to show this is an emergency, just his press release.
Can I get back to you?
And a form, a federal government form. That's all that was presented to justify. So,
could I get back to you on that?
Sure,
Okay.
sure.
All right.
Second. Yeah, so I'm actually looking at it right here. The documentary evidence presented was the governor's press release, a copy of the statute itself, the notice of the public meeting, and I don't even know what this is, like a page out of a handbook of some sort. I just felt that was kind of lacking. You know, there was something lacking there to show that this was an emergency. And I'll just wrap up. I think I don't think this is a small thing. This is a huge expansion, and I think what we're hearing on our side is that the General Assembly wants to have a say in that expansion. We want to have a say in how, $38 million is allocated, or, as Representative Bridges clearly states, appropriated. We're appropriating funds, and we're appropriating funds in an area where there's been tremendous complaints about reimbursements already. So I can't speak for the entire General Assembly, but I'm sure some of our members would probably say, let's get the reimbursement thing fixed first before we start throwing money down this hole. But at the very least, the General Assembly should have a say first. So I'll give back to you, Mr. Chairman, see if there's other questions, but I will have a motion shortly.
Thank you, Co-Chair. Senator Thayer.
Thank you, Mr. Chairman. This is just another example of Governor Beshear's complete and total dismissiveness towards the General Assembly. He's the governor of the executive branch of the Commonwealth, not the supreme potentate of 4.5 million people who live here. I'd make the motion myself, but I'm going to defer to my colleague in the Senate, Co-Chairman West. Can't wait to vote.
Mr. West, or Senator West.
Thank you, Mr. Chair. If it is in order, I would make a motion of deficiency for 907 KR 1026E, 907 KR 1026, 907 KR 1038E, 907 KR 1038, 907 KR 1632E, 907 KR 1632.
There is a motion to find the regulations deficient. Is there a second?
Second.
The question is on the motion to find the regulations deficient. All those in favor of finding the regulation deficient will vote aye. Those opposed will vote no. Madam Secretary, please call the roll.
Senator Rocky Adams. Senator Thayer.
Aye.
Senator Yates. Representative Bridges.
I'd like to vote aye, and with a little explanation. This is definitely an appropriations measure. This is, and the timing of this is very unusual. Usually we get these when we're not in session. We are in session. We can make statute. We can make appropriations. And yet, rather than bring it to the General Assembly or to a legislator in General Assembly, I've not seen one bill filed to address this. And this is the time to do it. And I'm very disappointed. I think each branch ought to stay in their lane, and this is a perfect example where one branch has got out of their lane. Thank you, Mr. Chair.
Representative Frazier Gordon? Yes. Representative Grossberg?
Pass.
Co-Chair West?
Aye.
And Co-Chair Lewis?
I'm going to explain my vote. I understand the intent. I appreciate what you do. As a body, we want to work with you all. I'll echo the comments from Senator Thayer. Just been disappointed. We want to work with you all. We want to help advance Kentuckians. So with that, I am also an aye.
We have 5 votes needed to pass a motion, and we have 6 ayes.
The motion to find these regulations deficient has passed. If there are no further questions or comments from our members, I'll entertain a motion to adjourn.
Motion to adjourn.
Second.
Next meeting, we're looking at March 7th at 8 a.m. again. Probably this room. After next week, next month, we should be able to go back to regularly scheduled programming.
Thank you all for coming. Thanks for our rock star staff as well. We appreciate you.
Clearly, you weren't one of the 9 people watching you on KHEAA until 9.
What's more important, the business of the Commonwealth or KET?
Or my sleep pattern severely disrupted, and therefore I can't tell when you're from. That is the sweetest thing you have said to me in a long time, Steve West. Well played on the pass, Grossberg.